Thank
to
you.
have you on our forum in this particular regard. And I think it's a very good case. I've completely gone through the presentation.
Okay.
Wonderful, wonderful presentation you have put together, and it's a very rare case rather.
Yes, sir. So my teammate has done it. I've co-guided her, so thought of presenting the same. So
Oh, okay. Good. I think so. It's come out very nicely in this regard, and I
okay.
hope this program will be really look forward to. Many of the people were telling that yes, we are looking forward to this
Yeah,
presentation
definitely.
in this regard. Okay.
Thanks
So
for the
rest.
initiative. That too, this kind of elaborate case studies, it's good for the all the junior dietitians also.
Absolutely,
That with
absolutely.
big platform they can avail all the. When I joined the first case study, it was really good. Second one I missed. So upcoming studies, hope me and my teammates can join.
Yes. Something new and innovative. We keep trying
Innovative,
every year,
yes.
and this is one among that. And then the first two programs went on very well. I think so in this
Okay,
regard. Okay.
great. Happy to know.
Rest, how
Okay.
is your routine?
All good, sir.
All
Title.
good?
Yeah, all going fine.
So, yeah, we'll catch up subsequently
All right.
whenever I can.
Yeah.
Okay, right. Thank you. Bye.
Good afternoon, Dr. Manju.
Hi, good afternoon, Dr. Harsh.
Yeah, so
Nice
all set?
all set, yeah.
Yeah, I was thinking, where to start. I realized looking at the case is too vast. I can start from anywhere. I'll be able to complete it. I'm sure a lot of effort has gone into
Yes,
preparing
yes.
this. Huge amount of effort, because it encompasses everything practically you can think of. Where what could be wrong, you know. So I'm
A
sure,
great team effort, yes.
yeah, it's a great learning experience for us also, because we always manage to pick up something new.
This platform is really good, sir. I too felt that last year also case studies were like it was something different than the routine cases. So good judges also. That panel also was good, good takeaways. So thanks for the introducing the same to all dietitians. Great teamwork has gone from Pulse.
Yes, Ramesh, the next initiative.
True.
Ramesh has
Haji, it is all a team effort. Totally, it is real. Mr. Kiran, you, and of course, the other members
Yeah,
of the head
everyone
office are put
is
together. Yeah.
definitely.
you
Yeah.
can't shy away
Top to
from taking
bottom,
credit. No?
we could feel that.
Yeah.
So, Dr. George, I'll do it like this. I'll begin the session, talk briefly,
Yeah.
then I introduce you. I have a slide,
Okay.
and then I hand over the session to you. All right.
Okay.
And then at the end, I come back if there are any question answers or anything is there. So, we'll not take questions in between. We'll only take it at the end.
All right.
Yeah, that is how we do it. Ramesh, that's fine.
Absolutely. I think so. I think Saurabh has got divided this presentation into these three parts, maybe to
Yes.
Yes.
incorporate those questions and so on. I think Saurabh, if you are there, you can give us this thing, no? What do
Yeah,
you
how are
call?
you going to tackle that quiz thing? How
Yeah,
does it
yeah.
come?
Sir,
Yeah.
I have already done dry
We have
test
done
with
it in the
Dr. Manju
afternoon.
Oh,
ma'am in
lovely.
the
I think you people
afternoon.
have done a trial run also. Wonderful,
Yes, sir.
wonderful.
Yeah. Oh,
Okay.
that's great. That's great.
Okay, yeah. Perfect. Okay.
Sure. So we have 8 minutes to go.
Okay, we'll wait for the participants to join.
Yes.
Yes.
All right.
Yeah.
Okay, then all the best to
They are
everyone.
linking up, I think so.
Okay, sir.
Yeah. Thank you.
Right.
Thank you.
Sir, I've kept them in the waiting room. Shall I remove the waiting room and they'll start joining?
I think we should start allowing them slowly in this regard so that we can start exactly at 3:30 sharp.
Okay.
Okay.
I'm here. Ramesh.
Dr. Harsh?
Yeah. Yeah, Ramesh.
Uh, yeah, couple of minutes we will wait. Around 30 people have already joined.
Hmm.
Maybe a few minutes, then we will start. 1 or 2 minutes we'll give them to log in this regard.
Yeah, fair enough. Because I think they have to put in their names and emails and register, and then they are.
Absolutely. A quick registration and then they
Yeah,
get the login,
So,
what do you call, through their mail in this regard.
okay.
Okay, yeah.
Do we start in 5 minutes? Should we say that?
Yeah, perfect. 5 minutes should be perfect, I think so.
Take it. Because let's not penalize who have joined on time.
No, absolutely right.
Yeah.
3:35 sharp.
Done.
Okay,
That's
sir.
fine.
Right. Dr. Harsh?
Yeah.
I think we can slowly set up and start off.
Okay.
I think we have almost around 55 participants already on board. Yeah.
Dr. George, shall we start?
Yeah, we can.
Take it. A very good evening, ladies and gentlemen. This is Dr. Harsh Chaturvedi, representing Pulse NutriScience and the NutriHealth Foundation, welcoming you to a very exciting evening. We call it Pulse NutriQuiz August 2026, which is a case-based clinical nutrition challenge on beyond wound healing, the critical care of role of nutrition in severe degloving injury. We have a very eminent faculty with us in Dr. Manju George, who will be taking us through a case uh, which, as much as I have seen it, encompasses everything. There was so much to learn here because, at least as far as I am concerned, my knowledge has typically been limited to treatment strategies when we are focusing on the wound healing, on antimicrobials and topical agents. And somewhere the role of nutrition uh, in preoperative optimization, in postoperative outcomes, and also importantly in the aesthetic outcomes, it's so very crucial. It gets missed on us. When I was thinking of doing this program, I had an opportunity to read through a few things, which made me realize that how energy intensive can be the wound healing process, and therefore a huge array of both micro and micronutrients they are required to restore the skin integrity. Macronutrients, obviously, the carbohydrates, fats, and proteins, and the fluids, and then the vitamins. We generally thought, okay, maybe vitamin C because it is imperative to have it for the collagen synthesis. But then I realized the roles which have been played by vitamin A and zinc and their contribution to the epithelial growth, to angiogenesis, to collagen synthesis, wound strength, and the epithelialization. So all this put together, uh, it makes a very complex but a very fascinating case which Dr. George has designed for us. And probably somewhere the patient, if I recollect correctly, is uh, is a diabetic. So on one hand, we have caloric demands coming in for protein synthesis. On the other hand, we are trying to have a tight glycemic regulation so that the fibroblasts and other things involved like endothelial cells they are able to function properly. I do believe the case she is going to dwell on also is somewhere has been consuming alcohol. I don't know the fellow person is smoker or not, but yes, smoking, especially nicotine, affecting the microcirculation, causing vasoconstriction, and limiting the wound healing. And at the same time, if the chronic alcohol use is there, so that increases the incidence of surgical wound infections and it also impairs wound healing. So all in all, we have a very exciting evening uh, with Dr. Manju George with us. Uh, Dr. George, welcome. I would only read a few lines about you. Dr. George is a chief dietitian from BPS Lakeshore Hospital at Kochi. She has more than 22 years of experience in clinical nutrition. She has done a PhD in food science and nutrition. She is an expert committee member of PM Poshan scheme in Kerala. She has done an advanced training in IBS from Monash University. She has multiple national and international awards to her credit. She is a resource person for national and international nutrition programs, and above all, is a keen researcher who has published 11 articles in index journals, and she has also written 5 book chapters. With these words, I welcome you, Dr. George, to this very exciting learning session. And we all look forward to be able to learn from you and realize how important is nutrition. It's just not only about antibiotics and topicals, maybe PDGFs and so on and so forth. There are other things also. So it was all over to you, Dr. George. Please take us through with your presentation. Thank you.
Thank you, Dr. Harsh. Very good evening, one and all present here. Many thanks once again to Pulse NutriScience, all the organizers, Ramesh sir, Dr. Harsh, Sweshika, and everybody who is involved here, and NutriHealth Foundation also. And I was discussing with them, this is a very good platform so that learning and more takeaways can be done. Even we learn and we gain knowledge from each and every program what they conduct. So it's really good, and I attended the first session this NutriQuest, and it was really good. The quiz program is also very interesting and rewarding, so that's more making more interesting to join, participate in this. So many thanks for the introduction once again. Without wasting much time, let me start the session. We have screened a few cases in our hospital and felt this would be a different case or in critical care, because we were personally involved in this case for a long time. In the critical care setting, I was taking care of this patient, and when he got shifted to the ward, my colleague Ms. Aparna had done the follow-up and along with other dietitians. And Aparna has helped me in doing this case study in such a wonderful manner, and many thanks to her also at this juncture. And beyond wound healing, the critical role of nutrition and severe deglowing injury is the title we have given. Next slide. So we know that deglowing injuries are usually associated with high energy trauma and can be devastating. We have seen many of the RTA cases. Those who are working in the hospital setup would have seen many RTA and other trauma cases. And such a case was really very shocking to see. And we received him from another hospital after a few days of treatment over there. Here, he had intense pain. In the initial stage, he had heavy bleeding, and the symptoms almost, it was connecting with those. There was visible detachment of the skin, extensive bruising and swelling, numbness, and potential exposure end of bone, muscle, and tendon was also seen. All these symptoms were visible over there. This when the superficial fascia separates from the deep fascia in a shearing mechanism, this deglowing occurs. This not only disrupts the vascular and lymphatic channels that span these two layers, but creates a potential space for fluid collection. So we can imagine that the risk of infection too is very high in this case, such cases. Next slide. We can see around majorly two types of deglowing injuries, where the open deglowing is where the skin is ripped open or torn off completely, leaving bone, tendon, or muscle exposed. And closed deglowing is where the top layer of the skin stays intact but separates from the tissue underneath, creating a hidden pocket that fills with blood and fluid known as moral lavulation. So these are the two types of deglowing injuries. Next slide. Here we got the patient, received the patient on the in November 2025, Mr. J, age 62 years, male. His occupation was, he was a moderate worker. Then admission date was 22nd November 2025. Next day, the assessment was done as per the NABH protocol. We have to do assessment screening within 24 hours of admission. So evening he was admitted. Next day morning he was assessed. He had a more length of stay was there in the hospital, around 62 days. So he had systemic comorbidity, otherwise no diabetes or nothing like that. And he was received from elsewhere with an alleged history of road traffic accident. He sustained extensive deglowing injuries to the left lower limb, exposed and unstable knee joint, necrotic muscles, and deep abrasion over right lower limb. He underwent multiple wound debridements earlier. negative pressure wound therapy was all, dressings were done, and tracheostomy was done elsewhere. Then he was referred to us on 22nd November 2025 for the management. So diagnosis says that it was a crush injury, left lower limb with deglowing wound from left groin to leg, open unstable knee joint, necrotic muscles, deep abrasions over right lower limb. Septic shock was there when we received him with multi-organ dysfunction syndrome. Tracheostomy was there and he was on inotropic support. Next slide. This is the course of treatment in the hospital. You can see multiple wound debridements were done under general anesthesia, and more long hours of NPO was there, and he had to withstand to the diet again. We received him he was NPO when he was received in our hospital, and he was on a long term, in at least 5 days he was on NPO, only on IV support. And in between that, we started feeds, and later only the oral diet started when he was stable. And then in between, wound debridements were happening, dressings were done. And on 5th December, the left above knee amputation was done. They were not willing for the knee amputation earlier. If it had done as we received him or in the beginning itself, that much of infection wouldn't have happened. But later things got worsened, and the family and himself agreed for the knee amputation. And once it was done, he started becoming stable. Then change of dressing we can see. Again, on the 5th of January 2026, wound debridement and split thickness skin grafting was also done. So many procedures here underwent. Next slide. And you can see the case we just discussed that he had a long portion the skin was torn and the skin was exposed. So continuous bowel movements were there. The sepsis was there's no sepsis in the initial stage, but there were chances, and slowly it started developing. And with too much of, like, it's not diarrhea, but watery stools were there. It's not because of the diet, but because of the condition. It just happened like that, and there was no muscles to keep the stool. So the portion was continuously wet. So the doctors have done the transverse loop colostomy, where the loop colostomy is a specific type of colostomy where a looped section of the colon is lifted onto the abdomen and opened, creating a single stoma with two distinct openings. This was nothing to do with such a condition, but in this case, they wanted to stop the diarrhea, and the bed sore and those risks were to be avoided. So for that, they did this colostomy, loop colostomy. Next slide. While coming to the nutrition screening and assessment, here we have subjective global assessment as screening and assessment tool with the AMR system. Otherwise, we can do multiple screening tools are there. We have GLIM is there for critical care setting. MUST score is there. So whichever is useful for your setup, it can be used, which is relevant for this condition. Here we did this SGA for him. Obviously the status was he was severely malnourished. Doctors have done the SOFA score. It is sequential organ failure assessment. The points were 5. That also showed severe malnutrition, and the risk was high. His previous usual weight was around 60-65 kg, and we couldn't assess the weight, but it was the calculation by the medical team and the nursing team informed us that he was around 60 kg as when we received him. His height measure was received from the bystanders, and thus we could find the details for our nutrition calculations. So this was the screening and assessment pattern, which is noted here. So with this, I think we have a break.
Good afternoon, everyone. My name is Saurabh. I'll quickly take you through on how to join the quiz. I'll explain the step-by-step guide on how to join the quiz. You must have received an email of the quiz joining link. The link is also dropped in the chat box. Please click on that chat box. Click on the chat box and open the link given in that. Or else you can join through your the link given in the mail also. Once you click on the link, it will take you to the platform. There you have to enter your name and registered email ID and click on Join Slido. After clicking on Join Slido, you will receive an access code in your email ID. And please enter that access code and click on Confirm. The access code is shown in the step 4. This is how you will get the access code. Please enter that and click on Confirm. After confirmation, you just need to click on the join button. It will be displayed there. So if you have joined, you need to just wait. The moderator will start the quiz from their end. You can select the answers when the quiz will be started and just click on send. Once your response is submitted, wait for the next question. Do not refresh or change the tab. And after each 5 questions, please return to the Zoom meeting to continue the other live case discussion. Will be delivered in your mail ID. Once you enter your name, email ID, click on join in the platform and access code you will get in your mail ID, in your email. Yes, those who are saying that there is no any question, please wait, the questions will be started from here. Yeah, it must be showing no active polls at this moment because the quizzes has not been started yet. We are waiting for the people to join. 47 has joined. We have 89 participants here. Please join everyone. Click on the link given in the mail. Zoom chat also it will be given. Fifty people has joined so far. We have 88 people who are watching. We'll start our quiz at 55. 3:55. You will get the OTP on your registered email ID. The email ID which you have used to register the NutriQuiz, the emails will be received on that. Please enter that email only, the one which you have used for registration. Please do not use any different mail ID. Please use the email ID which you have already registered. I have sent the link again in the chat box. Please drop a message in the text box if you are facing an issue. People who have joined, it must be showing as no active polls. I'll start from the here quiz, then you will get to see the quizzes. Please wait on that screen only. Okay, now the quiz has begun. I'm starting the quizzes. Here comes the first question on your screen. Please start attempting. The question is, which description best defines the degloving injury? The first question is logged. We are moving to the next question. The second question is on your screen. You can see the question is, which type of degloving injury is characterized by intact skin separating from the underlying tissue, forming a hidden pocket containing blood and fluid? Now we are moving to the third question. The third question is, which screening tool could have been used otherwise in the critical care setup? The winners will be decided based upon the fastest finger. The third question is also done. We are moving to the fourth question. Fourth question you can see on your phone. It's PES statement in a dime fits with. We are moving to the fifth question now. Any underlying malnutrition concerns to be ruled out before setting up the nutrition goals. Okay. Now you can switch back to the Zoom. The rest of the academic session will be taken over by Dr. Manju.
Okay, thank you. I'm not able to open my video.
Oh, 1 second, ma'am.
Yeah.
Ma'am, is it fine now?
No,
No, we can't see her.
you cannot start a video because it is disabled by the host. That's what the message is.
Oh,
Yeah,
yes.
just check once.
Yes, just 1 second.
Yeah.
Now you can do that, sir.
Yeah, done.
Yeah,
Thank you.
yeah, she's there. Thanks. Yeah.
Thank you. I hope that was quite impressive and within no time, everyone had to answer. That's really good. So we'll continue with the session, the presentation. for any nutrition program what we run, we have to screen the patient, right? The assessment, the ADIME is the major tool what we use, the major focus point where all the nutrition care plan happens in that. So with that, we have done the screening, and now this assessment is also done. Now, along with that, in the assessment techniques, biochemical parameters also play a major role, where we see the current
George,
pattern
is that so?
or previously what was the imbalance the patient had. All those data we can first see with the biochemical parameters. But same as in the case of burns, in the burns case, we can see the albumin level is not that, maybe it is little high or it is not that changed. But laterally, we'll get to know the variation in the serum albumin level. Here also, we can't see not much of a major problem with the biochemical pattern. Because of the long hospital stay, his serum albumin was slightly low. But that, as we know, that is not considered as the major indicator for malnutrition. And these are just 3 days values, but major biochemical parameters what we need to screen is, especially we got him as nil per oral. He was not eating anything. His home recall will be discussed in the upcoming slides. But we could see that his nutrition was really compromised. And once we start the diet, we received him with a tracheostomy. And once we start the feeds or the tube feeds, we all know that we should start slow. Otherwise, what happens? We know he's in a major catabolic state with protein breakdown. Yes, that is really understood and expected in this case. Plus, if we give him a calorie or nutrient dense diet, either through enterally or parenterally or through orally if possible, it would invite problems like refeeding syndrome. So that needs to be taken care. And I don't think refeeding needs to be explained over here, because the clinical setup, we all consider this. But in such cases, after a prolonged starvation, when we give a flush of nutrients, the body, the certain elements or the electrolytes will start varying and the patient will go to a shock otherwise. So along with the routine biochemical parameters, we should develop a refeeding protocol also in our hospital. Here, the nutritionist was given a major role by the critical care doctor and also the plastic surgeon who treated the patient. So that's what we could feel more confidence, because they asked us to plan his nutrition care. Not only the diet part alone, but the tests also, these two sections, the doctors asked us to plan. So we were actually like, usually we see doctors suggesting tests and we go by the result and do it. But here, doctors gave us all the freedom to check other than what they were writing the parameters. So you also plan whatever things which are needed to be nutritionally relevant and which could show the significant malnutrition. So we thought of this, and I definitely took a help of one of the senior dietitians in our fraternity, and she also really helped in this case, so that the initial concerns were addressed, and certain medicine combinations also were suggested, which we had in our hospital, but suggestions were given to the doctors. They were also ready to explore those options. That was happening. And we didn't routinely screen this, but the refeeding protocol, we have to enter the phosphorus, definitely, calcium, magnesium, and potassium. These 4 things are to be done along with the vitals we see. Serum albumin, yes, for the colloidal osmotic pressure and other major metabolic changes will happen. So to assess that, we have to assess, but not as a marker for defining malnutrition. And rest of the parameters were assessed, and routine tests were not done regularly. So with 1-day test, after 2-3 days only, the next level of round of tests were being done. So with that, we could see whether the treatment and nutrition plan was going as a success or positive. So we could assess the importance of planning a multidisciplinary approach along with the results observed. So that was the major change we could promote in this case. As a teamwork, we could win this case. And he came in such a bad condition that we didn't expect him to come back to life, because sepsis was gradually worsening. Initially it was not there, but later we could feel it is, and that too with diarrhea. The continuous bowel movements, watery stools were there. Though it is not nutrition related, because of the multi-organ dysfunction syndrome, it also happened. So with that, we had more challenges in front of us to deal with this case. So here, next slide. Medications also, I haven't added a lot of medications, majorly to control the diarrhea, and antibiotics were there, and rest of the medications were for the support and all. Then once assessing this electrolytes, we could see he was at the verge of refeeding, starting the refeeding syndrome. So the feeds were planned in such a way that slowly we have to start. But initially he was not in a position to start the enteral feeds also. So what we could do? We thought of starting TPN, but that also he was not in a position to receive the total parenteral nutrition, and the prolonged hospital stay, the cost and those things were also under consideration. So better cost effectively how we can do. So we gave him 1 day of amino acid supplementation, and since sepsis was not that high but slowly started, so glutamine also was in plan. It was written, and along with the multivitamin and mineral supplementation, we started the plan with other medications as per the protocol. Then challenges started when we started enteral feeding. Next slide. So before that, let me go on to the home recall. Definitely the patient was not in a position to speak. So his bystanders were interviewed to assess the home recall. We could see that at home also, before the injury happened, his intake was not that good. He was not having any bad habits as per them, but intake was not adequate. So there was still a chance for malnutrition. And once we received him, as I mentioned, there was a fasting period for more than 5 days, and previously in the previous setup also the nutrition would have compromised because of these conditions. So with that, a PES statement was developed. This is the universal language of dietitians, as we all know: problem, etiology, signs and symptoms. So anywhere this patient goes, if the PES statement is done, that speaks the same word. Multiple PES statements can be, we can create multiple PES statements based on each condition. So 1 or 2 attempts are done here. One was suboptimal nutrient intake related to impaired gut function as evidenced by frequent diarrhea. The other one was inadequate protein intake related to prolonged hospital stay as evidenced by severe muscle wasting. We can even evolve more of such kind of statement based on each of his conditions. So I would suggest all our dietitians to practice writing the PES statements, that the nutrition diagnosis is universally done in a common language. Next slide. Yeah, and again a break time.
Yes, you can simply click on this link provided in the chat, or just switch your tab and get back to the quiz page. Another 5 questions will be displayed on your screen now. Okay. So the 6th question is about the start. The 6th question is, following major trauma, which metabolic response is most characteristic? Question 6 is done. We are moving to the 7th question. Question 7 is which is not a reliable standalone marker of nutritional status in critically ill patients? Seventh question is also locked. Now we are moving to the eighth question. Question 8 is when hypoalbuminemia is observed, it's better to what?
Admit all.
Now we are moving to the ninth question. Question 9 is essential tests to be included in the refeeding protocol. So 76 people has joined, please confirm that. Okay. Now the 10th question here it is. Which vitamin should be given to reduce the risk of Wernicke's encephalopathy during refeeding? All right, now you can switch back to the academic session.
Thank you. Good to see the polls.
Yes.
So good. Now we are coming to the planning, nutrient prescription. There are multiple centers adopting different ways to plan the nutrient prescription. I have seen Harris-Benedict equation in certain centers and especially interns when they come to learn the practicals, and a few hospitals also. But here we use weight-based equation. We know the gold standard is indirect calorimetry, but every hospitals will not have the setup for that. So depending on the protocol developed, we can use the same. Here in our center, we used based on the current weight and the high calorie or high nutrient dense formula. So we just compared what difference it could make with the Harris-Benedict. So it both came as more or less equal with the stress factor, activity level, everything involved. The energy expenditure by the energy requirement by the Harris-Benedict also showed around 2,700 calories, and the weight-based equation with the high calorie per kilogram actual body weight also showed almost the same energy requirement. And protein, we started the goal same like Burns case, or with the stress factor also we could see up 2 gram per kilogram body weight. And if he was tolerating, you are again ready to increase the protein because he would have already lost major muscle mass and still the catabolism was severely high. So at least 2 gram per kilogram body weight we intended. There were some variations in the creatinine and serum creatinine RFT levels, but later it got resolved with proper hydration. So we did not have a challenge in giving a higher protein requirement, higher protein provision at that time. Fat was listed as normal. Anyway, we are not giving an extra fat as oil or any other sources because of the diarrheal episodes. But whatever with the feeds we were planned, it was given. And once he got better, we could give additional fat to meet the energy expenditure. And fluids were given properly, at least 3 to 4 liters a day, including IV fluids. Then while observing the continuous diarrhea, we had a thought with the medical team whether to decrease the fluids and support IV fluids. But that was not found practical because the patient would have felt or would have experienced more nutrient loss otherwise. So that was not intended. It was given adequate to the requirement. And thiamine also was provided, as you all polled, majority of you polled rightly. That also had a very significant role in this. So that's how the nutrient prescription evolved with the major macronutrients. Micros, as we mentioned, main micros were considered, and we were checking if the multi-nutrient multi-mineral, multi-vitamin supplementation was ongoing. It was given for first 5 days and then stopped, and then later after processing only it was restarted. So next slide. While coming to the goals of nutrition care, there were short-term and long-term goals. Short-term goals included adequate fluid and electrolyte balance to correct the current situation, provide micro and macronutrients to prevent muscle wasting and thus by reducing malnutrition, maintain high normoglycemia, because there were slight variation even though he was not diabetic because of the catabolic factors. There were slightly glycemic excursions were seen. So that was should be corrected so that we are not giving extra sugars or additional simple sugars to the feeds. Then provide immunonutrients if indicated. There was indication, but we were a little worried because sepsis was reported. So we just halt for a few days, and then we started glutamine supplementation. Why? Because so that the wound healing it supports. There are studies where it shows positive and plus or minus feedbacks with glutamine supplementation, but in this case and also in mucositis cases, we could feel there's the time-bound provision, at least for 5 days or 7 days, based on the weight we can give, and that showed some benefit in this case also. And there was continuous dressing and the complete wound healing along with the medication. We expected some support with this, and that worked. Initially it was given as central, and later when he started oral diet, he was consuming it orally also. So again, when there is any sepsis attack or any fever reported, we stopped those, and once it is resolved, we restarted. So it was not continuous, but based on the condition, it was provided. Then since the colostomy, loop colostomy was done, there was the stoma was high. What is high output stoma? Where the stomal volume, if it is high, the patients, the more the fluids are going like that. So we need to stop the higher stomal output, dietary nutrition wise. That was initially that the list will be given in the later slides, and if it is more than 1500 ml, that is called as high output stoma. He had 1200, 1400 like that. So we expected a high output stoma, and we modified the feeds accordingly so that it can be done a little lesser, and it also worked. So that was short-term plan over here. And long-term plans included ensure his proper weight gain through proper muscle development and prevent malnutrition, promote complete wound healing, improve overall health status. That was the major goal. And plus surgery team was very particular that even if there is a slight delay in achieving the nutrition goal, no diarrhea should happen so that the wound dressing should not get infected. So we were not very aggressive, but very careful in managing the plan. He was on and off. He was coming back to ICU after wound debridement for observation, then back to room. So these two cares, the bystanders also cooperate very nicely, and this man was also very cooperative so that we could tell them why this is introduced, and they were responding to whatever suggestions were provided. That was major change in managing the challenge of this nutrient prescription and achieving the goal. Here you can, next slide. Here you can see the diet progression during the hospital stay. See how many days of NPO in between the enteral feeds, and many surgeries have happened, as I mentioned earlier. So day 6 onwards, the nasogastric feed was started in slow volume so that the refeeding is addressed and taken care. Slowly the feed volume got increased as per the tolerance. Again, wound debridement happened and multiple surgeries happened. So even though we noted it as 100 ml per hour, it is the initially post NPO status, the feeds were started at a low rate and then gradually it was increased. So that's how we could achieve, to an extent the goals were achieved, but I won't say 100% because that was not possible in this kind of dressing and NPO status and these areas. So we can see by the day 46, he started the oral diet. And slowly, along with the oral diet also, we could supplement him. The nutrition, oral nutrition supplement was provided for stepping up the overall nutrition. Plus, protein sources were given in multiple different forms of as blends, or even eggs were provided. 4 to 5 eggs were, whole eggs were provided. Additional egg whites were provided. And it boiled form, people may not be liking it. So different custards or shakes or mixed forms it was provided. And there was a multivitamin gummy. We just tried to see because multivitamin injections were stopped. So diet was the only source where he was getting it, and otherwise any variation happens in the biochemical values, the medication wise it will be started. So we just discussed with doctor whether we can start, and that was suggestion given from our end. So he said you go ahead, and so we were all having all the freedom to continue with our suggestions and to see how it gives a change. Definitely he had the stoma and there won't be anything excess. So he also was ready to have, and he liked the gummies. So it was a multivitamin gummy and we continued it for quite some time. And there was no that guideline. If you ask me, I won't have a guideline to show, but this was a case-to-case approach where we felt that this will be good for him, and he was during his recovery journey that supported. And I don't suggest everybody should start in such a critical care setup, but as I said, this was a case-to-case approach category, and where we tried the best possible nutrition patterns what we could implement there, and that supported the patient. And during this enteral feeds, we initially started a peptide-based formula with antidiarrheal model. That also he was, the feeds were tolerant, but the output was too high. So what we did to control the output was traditional method of blenderized feeds with, we have boiled banana, kela we call now. So banana blend and curd, the plain curd or salted lassi kind of thing. So these two are also included as 1 or 2 or 3 feeds with the routine gravity bag feeding. These blends were provided as bolus feeds because the bags may get blocked with this. So that in between, as soon as he is back from the NPO gets over after the wound debridement or in between. So that showed some benefit with the management of the high output stoma. Once we started orally, what we did was too hot or too cold things were avoided. He was suggested to have the food in room temperature, reduce the liquids along with the solid foods. Any liquids what he was consuming, it was semi thick or semi blended, and water separately, so that fluid also was maintained along with managing his nutrient density. Next slide. Hospital recall, the graph indicates energy and protein. You can see up to 2000 calories were met by the as a day 5 recall by January 2026, and protein intake was slightly, but it was better and slowly improving by the end of the 5th day recall. So there were ups and downs in between, but the graph was not going down, even though because of the surgery and other procedures, we could not match daily recall like this, but the average value showed a better improvement in this. Next slide. Prescribed diet model is also given here. We gave a moderate fiber high protein diet because of the stoma, and he was ready to eat everything, but we didn't want a problem with the stoma. So soluble fiber was provided. Along with that, the antidiarrheal mode of blends as needed, not daily, but as indicated. Plus, encouraged to have more soluble fiber included, proteinaceous diet, better chew and consume, and he was amputated, so he was started walking with the crutches. So slightly that physical activity and physiotherapy also was started. He was very weak, muscular volume was gone down because of prolonged hospital stay, but with continuous support from the multidisciplinary team, he was ready to do the exercises and he was obeying all the commands. So with the support of all the teammates, we slowly achieved the goal, and the prescribed diet showed around 2630 calories and 116 gram protein. Next slide. This is a comparison of hospital diet and prescribed diet with suggested intake. We can see suggested intake as the modified RDA, and in the hospital there was around we could achieve the goal as prescribed, but energy wise around 26.6% deficit only was seen. That too in such a condition we could achieve that much. But in the prescribed diet, there were not much of variations, and he was ready to consume the prescribed items along with the oral supplement and the nutrition support methods what we suggested him. Fiber, majorly it was soluble fiber, not the insoluble fibers were restricted in the initial stage, but after that, slowly as per his tolerance, it was slowly included. Next slide. So this in that admission, as the conclusion side was done as Mr. J with this given history was referred to our hospital in November 2025. High risk categories identified as per the screening and assessment tool. All the procedures as discussed, it was done. We could see hypoalbuminemia, the verge of refeeding syndrome when we check the electrolytes as a refeeding protocol as per the hospital setup. And after all these tests and procedures and nutrition support, he was found better. The sepsis was over. So he got discharged on 22nd January 2026 after 62 days of hospital stay. At the time of discharge, we could not take his body weight because he was not able to stand properly, only with the support he was doing, and that was not accurate also. So at that stage, we could achieve the sepsis control with the person's better intake was started. His digestion was better, and overall nutrition was getting better. I won't say it was completely okay, but it was getting better, and the positive sign was seen. Next slide. Again, he got admitted in the month of March for the colostomy, for the stoma reversal. So that surgery was done, and the gastrosurgery team informed that the post-operative period was uneventful. Plus, surgery team also gave good feedback on his healing. So that was perfectly done, and he was tolerating, but the dietary intake was improved and condition was getting better. Next slide. As a follow-up, the colostomy closure was done, and he demonstrated clinical improvement in nutrition and physical status following the prolonged recovery from severe deglowing injury and multiple surgical interventions. Since we could not assess the body weight post-discharge, in the follow-up time we assessed, and it was 40 kg. There was a knee amputation and other catabolic responses. So there was expected weight loss was expected, and it was 40 kg, but he was slowly improving on the nutrition part. It was not degrading. His hand grip strength also was assessed at the time of the follow-up. That also showed weak because of the prolonged hospital stay, and the recovery phase is slowly getting better. And his movement started, and the routine physio was also being done. He communicated well. His face looked better. and the muscle wasting was severe. That was slowly getting better, and he was, and then later the follow-up was done, and he was slightly compared to the follow-up, initial follow-up, the betterment was observed in the next follow-up. So that overall impression was that individualized nutrition support with adequate energy and high quality protein and nutrition support together with regular nutritional reassessment and follow-up that facilitates ongoing rehabilitation, minimize risk of recurrent malnutrition. The back to hospital or ICU is really challenging, and it's difficult that we will not gain back the patient. So that did not happen in this case. Even the recovery was slow, we could make up that the consistency was good, so that he was obeying to the commands, and the follow-up from my team and also from the medical team was also assured, and thus we could give a positive response to the nutrition support plan. These are the references, and we can be ready for the next round of quiz.
Yes, thank you, doctor. Now you can just click on the link or switch the tab simply. Then the last 5 set of questions, you can start attempting. It has not started yet. I'll start from you. We will wait for 1 minute and start next questions. All right, so 11th question, you can start attempting. Question is, which hormone is primarily responsible for the intracellular shift of phosphate, potassium, and magnesium during refeeding? Okay, the 11th question is locked. Now you can attempt the 12th question. It is method to assess body weight of a bedridden patient in critical care is. Please attempt the 13th question. In the presented case, which approach was used to estimate the patient's energy requirement? You can start attempting the 14th question. Effective suggestion to control frequent bowel movements in the current scenario is. Right. This is the last question. What is the benchmark of a high output stomach? You can switch back to the Zoom. After a while, we will display the winners on the screen. Doctor, you can take over.
Thank you, Dr. George, for a very enlightening talk. And I'm sure that there will be people will have a lot of questions here. Uh, I'm just checking on the chats. I think you also have the access there.
എനിക്കറിയില്ല ഞാൻ ഇന്നലെ കഴിവതും മെസ്സേജ് അയക്കുന്നില്ല ചെയ്യാനും പറ്റുമെങ്കിൽ വിളിക്കത്തോളാം.
You can hear somebody speaking something. Ladies and gentlemen, you can pose your questions in the chat box, which is accessible to all of us.
സമാധാനം പോകില്ലോ നോക്കുക.
Are you still with the quiz, Saurabh?
No, sir, the quiz is done. Once you can take their questions, then we will display the leaderboard.
Okay.
They can ask questions.
Yeah. Dr. George, we have a question. Would you recommend measuring urinary sodium, serum magnesium, and potassium regularly in patients with a high output soma?
Yeah, I saw that, doctor.
Yeah.
In our practice, we did not do like that, but biochemical parameters, the serum sodium and potassium, they were doing every alternate day because of the cost concerns. Otherwise, it's good to see daily values. Magnesium, the refeeding protocol we can do, we did actually daily, it can be done when the patient is at risk of this developing this condition, but we did every alternate day here. So once with that we could see that was whether the plan was achieving the goal or was it getting deviated. So we could, the cost also can be managed, plus with the pattern, it was dietary measures are also managed. So once it was stable, we did once in 5 days. So things were stable and the continuous tests were not done. But serum sodium, chloride, potassium, it was done on every 3rd day otherwise.
Yes. So I hope Sharijit, who had asked this question, has got the thing. So another comes from Radhe Mohan Pal. What if a patient who is having diarrhea after surgery related to hemorrhoids happened? So how it can be managed at home?
Yeah. Or to a patient who is having diarrhea after surgery related to hemorrhoids.
Yes.
That depends on the intake. Definitely, we have to avoid insoluble fibers. Hemorrhoids, the bowel movement has to be, the soluble fiber can be given, but initially we have talked to the doctor whether how it's it planned. So anti-diarrheal, definitely we have, suppose if they are having diarrhea, we should avoid all the triggering foods like milk definitely can be limited, and soft foods can be provided, spicy and hot foods can be avoided. So these pattern has to be followed, and depending on the progress, you see whether soluble fiber is tolerant, because constipation also should not happen. So we have to go with the soluble fiber inclusion. Dietary wise will do, if not only soluble fiber supplements to be considered of, and more liquids, adequate liquids to be taken care. We have antidiarrheal liquids also if needed, like sago or arrowroot based liquids in case the patient is having diarrhea. So that will hold the system. If not, soluble fiber supplements also will support in getting the gut integrity. Curd based things can be added. So the dietary options we can see initially, and if not, only we can go with the medical support.
Yes. We again have Sharijit asking that you have calculated protein at 2 gram per kg using actual body weight. In a critically ill or injured patient with fluid shifts, edema, and altered body composition, would ideal or adjusted body weight be more appropriate? So,
Yeah,
which
very
one?
good
And how would
question.
you choose between the two?
True. Yeah, everybody will have this doubt. This again,
Yes.
many of them are, we follow with the adjusted ideal body weight actually. Because in this case, especially, we did not know the actual weight. Even though that was taken as 60 kg, he would have lost even more much loss would have happened. So he wouldn't maybe 50 or 55 or also, but we go with the medical team, and based on the common platform, we came to a conclusion that he was weighing that much at that time. So what with the ideal body weight, if we go, this prescription can be may not be the actual this thing. Suppose the patient is having 165 centimeters and weighing 90 kg. If we go with the ideal body weight, 60 or 65 into 1.5 or 2 will be there. Actual body weight also, it will be 95 into 1.5 or 2, but that will not stand stable. So based on this, adjusted ideal body weight is the ideal thing what we can use. Certain conditions, if we don't know the actual height measures, actually may not be there. So at that time, what we can do is take the current weight and approximate height. That is not scientific explanation, but still in our setup, sometimes we will have to depend on that. So otherwise, demispan kind of test we can do to measure the body height also. So with that, we can see if the patient needs a high calorie diet, the current weight, if it is he is underweight, the current underweight, that how much is the measure into 40 to 45 depending on the condition. If he is normal, ideal weight 30 or 32 or 35 can be given, and depending on that we can see whatever it is, we won't be able to achieve the goal in first 5 days or 7 days. So it has to be gradually done. So we can set the goal initially as per the current practice, and then depending on the patient tolerance and rest of the biochemical indications, we can modify it to the higher achieved pattern, and his homeostasis can be assessed, digestion can be checked, and gastrointestinal symptoms, all these things, if it comes to normal, yes, we are in the right path. If there is any variation happening, we can modify it as per.
So, Shari Ajit got the response. Madhula Sharma wants to know which type of fat could we start to this type of patients.
1 second, so I'll just see.
Yeah, it's
Which type of fat could we
fat,
start
yeah.
to this type of patients?
Uh,
Actually, there is no separate fat needs to be started. If at all needed, we can go with the MCT based. MCT is easily digestible. Body need not do much of an exercise to digest it. So you can, if you want to additionally give, MCT based fat source can be used. And oral diet, if he is doing and tolerating better, you can use normal fat. Whatever is the staple fat we are using for the normal cooking, it can be done. If the digestion is good, you can even use some ghee also, no problem, depending on the total fat. Up to 40%, 40% of total calories, we can meet the fat. We learned in our class that 30% of total calorie can be the fat source, but that is okay. Here his requirement is more. So some more fat can be given as the energy source, provided there are no other complications with providing that. So that can be adopted.
yeah, so ghee, coconut oil, anything can be given. Yeah.
Yeah, pure coconut oil, not the routine packed ones we
Yes.
do. There will be the pure coconut oil supports.
Mm.
Otherwise, we have commercial formulas also, MCT based, whichever is available, we can try that.
I have one thing also coming from Kritika Agarwal, which book she wants to know to gain knowledge about nutrition and diet in Hindi.
Very difficult to answer. We don't suggest books actually nowadays. We can go for the guidelines. ISPAN,
Yes.
ASPAN, and the local guidelines that will be more better, much better. For the exam purpose, we go with the books, but the guidelines change rapidly. Even
Yes.
though there are not much of variations, the pattern will be almost same. Slight variations only will happen, but latest guidelines, if we chose, will be up to date.
Yeah,
And
we are
we
more
have
updated with the guidelines.
Yes, we
They
have
are more dynamic. Yes.
Indian guidelines in certain specialities that'll be more supportive. If not Indian guidelines, we can go with the ASPAN protocol.
Yes. I'm sure because books publication takes a while, and things coming in the textbook takes a while. So it's better. And in today's age, with all the access that we have with the net, I'm sure the guidelines are much more handier. So that's there. Any other questions that we have?
Shefali has asked about MCT in the diet. Yes, you can. If he is
Yes.
tolerating well, in this case, when he started oral diet, since his normal intake was good, we didn't start. Otherwise, we can start. There is no harm in doing it. Basically, total fat percentage should match within the 40 or 45% of total energy expenditure, total energy provision. So with that, we can add MCT, or that there is no problem in having it. To increase, step up the nutrient and energy density of the diet, it can be done.
Yes. Anything else, ladies and gentlemen, that do we have? Any other questions you have?
So there
Pure.
was one more question missed. It was which supplements were used?
We used here whey protein supplement. Initially, it was peptide-based supplement for the enteral feeds. Then it was modified as peptide-based with the antidiarrheal blended feeds, as I mentioned. Then once he started the oral diet, it was changed to high protein whey protein supplement. Whey protein is supposed to be metabolized better in the muscles, so that
Yes.
support was provided.
Anything else which is there? Don't make it out.
Sir, there is one more question
Wow, which
at the
one?
last.
If the
How
patient is
can they get
vegetarian.
protein? Yeah.
Pure
Yeah,
vegetarian.
got it. Yeah, vegetarians, we can't give, if they are pure vegetarian, the egg source and non-veg source are completely cut. So we need to rely basically on the oral diet. Yes, we can go with paneer and pulses and soy-based products, but that will not be sufficient in maintaining 150 gram of proteins requirement. So here we will need to continue with the oral nutrient supplements to match the goal. So that along with the dietary protein has to be done.
So top it up, kind of a thing.
Yeah, top up.
Yeah. Fair enough. I think that's the end of the questions. Do we have the quiz results out with us?
Yes, sir.
Oh, so madam is going to announce the winner.
All right. All right, sir. I'm displaying the result.
Yes.
Here it is on the screen.
So the first one is Roshni P. Congratulations. You can see, madam, it's there on your screen, Dr. George. You can see it. The second
Congratulations.
prize is Sri Kuti S. Congratulations to Sri Kuti S. And third goes to Kritika Agarwal. At place 4, we have Raveen Kaur Anand. And at 5th, we have Uma Mangeshwari R. Congratulations to all the winners. And yes, it was about all have the same scores, I believe. It's only about
Depending on the
who
speed.
was the first one to press. I think so. So it's a fastest finger first kind of a thing that we have here.
Sure. Congratulations all. Congratulations Roshni and everyone.
Yes. So thank you so much. Do we have anything more to it? It's been a very enlightening session, and I was so engrossed in it. So much of learning was there. I hope that everybody has got the answers to questions, and everybody is going back wiser with the effort that has been put by Dr. Manju George. We'll continue to have this more and more. And if there's nothing else, then I thank you, Dr. George, for taking out time for us.
Thank you,
And
sir. Thank you,
for a
everyone.
very elaborate presentation, very elaborate, very thought-provoking thing. I'm sure a lot of hard work has gone into it.
Thanks a lot. Yeah, thanks. I would like to add one more thing. We could get involved in this case because the trust doctors gave us. So that's why
Yes.
we could, in fact, do more in our pan. So that we all of us have developed that trust, and then they'll give us more complicated cases to handle with. So
Yes.
that's the basic thing we learned from this experience. Thank you.
Yes.
Thank you once again.
Yeah. Thank you so much, madam, for joining us. Thank you, ladies and gentlemen. We sign it off from here at Pulse Nutrition.